Our next topic is we're going to talk about the LHON-Plus spectrum, and we are joined by Dr. Andrea Grootman and Dr. Ann Curamello, both at Children's National Medical Center, and I will let them take it away.
So happy to be here and talk about these things. And, just a kind of personal disclosure. So my mom actually had macular degeneration from a rare genetic condition. And so she did have Charles Bonnet, but back then, they didn't really know much about it. And, I know how debilitating it was and how when she lost her vision and couldn't drive, she lost her independence. So, growing up, I was sort of her eyes everywhere. And so, I really respect the fact that you're able to talk candidly about this and, certainly let your healthcare professionals know because it is a big deal. So with that, I'm going to talk about LHON, LHON-Plus, and LHON-MS. And there's a lot of confusion in terms of the semantics of that. So just to try to break it down a little bit in finer detail, why do we need to know that? Because it is an evolving spectrum of clinical symptoms that we're learning more and more about. So if you have just vision loss, we tend to refer to that as LHON or LHON. Multiple symptoms with or without vision loss along the spectrum, LHON-Plus and LHON-MS. So Leber's hereditary optic neuropathy is maternally inherited form of blindness due to a mutation in one of several genes in the mitochondrial genome. And although it predominantly affects males, we're now understanding that there's a broader spectrum of female involvement. And so the mitochondrial mutation can be silent until there's a trigger. And so we would consider those people to be initially asymptomatic, or that there can be, once the trigger causes vision loss, then those people would be considered symptomatic. And after the onset of vision loss, most patients will experience progressive worsening within months. There are several clinical trials for this disorder. So in distinction to some of the other mitochondrial disorders, things are actually a little bit further ahead with LHON for clinical trials. And idebenone is often prescribed. That's a synthetic coenzyme Q10. And also the FB743 analog has been shown to be effective in some patients as well. So again, these are progressive disorders. So we refer to them as neurodegeneration. So the optic nerve is actually a part of the brain. It's the ganglion cells are actually neurons. And so there can be also additional extraocular symptoms with or without vision loss in this continuum spectrum. And we refer to them as LHON-Plus or LHON-MS, predominantly affecting women. A large portion of patients will have visual impairment persisting in one eye for an unusually long period of time. It can be up to 2 years before both eyes are affected in the LHON-Plus and LHON-MS. And also patients can exhibit other symptoms, which can vary among patients. So not every patient necessarily has the same symptoms, and it can be throughout the progression of the disease. So they're not necessarily clustered in the beginning. When the vision loss comes, they can pretty much occur at any point. We ourselves with Alyssa have done a survey. This was de-identified information. So thanks to those who participated using a digital platform on the LHON-Plus Global Project, just to see, how is this distributed demographically? So as you see, women make up the majority, and older age is when we tend to see the symptoms. So although there can be symptoms in the very young children, it tends, at least in our population, to be predominantly affecting those over age 22. And then, curiously, most participants with LHON-Plus had at least one family member with LHON, as you can see here. So they were asked yes or no. So about 63 or 65% had a family member with. However, if you asked another question, how many of you had a family member with MS? It was the opposite. So very few actually had a family member with MS. And so what are some of those extraocular symptoms? And so many of you know these firsthand: neuropathy, the myopathy, muscle problems, tremors, Parkinsonism, dystonia or movement disorders, bladder spasm, or other types of urinary dysfunction, gastrointestinal dysmotility, anxiety, migraines, or other types of severe headaches, and cardiomyopathy. And so the clinical manifestations are very highly heterogeneous, as you can see here. So vision loss, predominant symptom, obviously, muscle weakness, hand tremors, but seizures in contradistinction to other types of mitochondrial disorders, very rare. And bladder spasm as well, very compared to other symptoms, common, but not as common. And so most patients with LHON-Plus get a LHON diagnosis. Okay, so when we asked you, how many of you were diagnosed with LHON? Almost 70%, LHON-Plus about 25%, and LHON-MS very few. Most LHON-Plus patients were diagnosed by a combination of ophthalmologic evaluation, brain MRI, and blood testing. So the blood testing to identify the genetic mutations, the brain MRI to rule in or out MS type features, and then you've heard about all the ophthalmologic evaluation. So the majority, many have had brain MRI, subsequent genetic testing, muscle biopsy, and not really necessarily a test that we use to diagnose this condition. So although some of the participants had a muscle biopsy, it's not really something that we would jump to. And skin biopsy for diagnosis, not really used, but Dr. Caramello will talk about skin biopsy and research implications. And so the extreme heterogeneity of the phenotype or the clinical manifestations is what makes the diagnostic challenge in this disorder. So the disease progression is variable amongst patients. So I guess I don't want to overuse the cliche, but if you see one patient with LHON-Plus, you've seen one patient with LHON-Plus because they're all different. Extra-ocular symptoms can vary even within the same family, amongst family members. We're learning about environmental modifiers to the symptoms and diet. Diet may be playing a very important role. There are really unreliable diagnostic algorithms at this point, and the absence of disease-specific biomarkers. There are only 2 non-specific blood biomarkers that are available to denote mitochondrial dysfunction, and that's the fibroblast growth factor 21 and the GDF15. In the absence of curative treatment, patients are often put on the mitochondrial cocktail. And so depending on your provider, what is in the cocktail may vary. It may include CoQ10 or idebenone, which is a synthetic CoQ10. And that tends to have the most efficacy on vision loss. Carnitine, riboflavin or vitamin B2, thiamine or vitamin B1, lipoic acid, vitamin C or vitamin K. And then so I'm going to pass it on to my colleague. And I apologize, I have to leave to go back over to the Leigh syndrome. They have me ping-ponging today, but thanks so much for your attention.
Thank you so much for joining us. As she said, we grabbed her away from her other session to come in, give a little talk, but now her colleague, Dr. Caramello, will give us a little bit more time because she always gives us so much time. So
thank you, everyone. Yeah, okay. So first I want to thank Lisa. I've been working with Lisa and Lisa, who is in here for many, many years, and I really applaud their leadership and to bring forward this LHON project. And not only they brought awareness, but they brought it to a national and international platform. So I think that deserve all kind of credits. So I just want to expand from what James and Elizabeth said earlier, but bringing at a much higher level, the cellular level. And that's the rest of the presentation will be to really try to address some of the questions, especially several questions in the back here that really went after why this clinical heterogeneity, why this genetic heterogeneity, and why do we have so many variables among patients. So it's a mystery box. I'm not pretending I just can solve the mystery, but I'm just going to present some clues that we have. So to recapitulate what James said, that no, that's not what I want. This. So a cell, any cell that we have in the organism, in the body, have like many mitochondria. So a cell has not just one mitochondrion, but multiple mitochondrions. So that's why you end up having a mixed population. And then the mitochondrion by itself is just semi-autonomous, meaning that it has its own genome, the mitochondrial DNA genome that James went over. So I'm not going to go over that, but it needs a helper. And the helper is what we call the nuclear genome located in your chromosomes. And together they form that organelle. But since the mitochondrial genome is so tiny, it only encodes 13 proteins, it needs a lot of help from the nuclear genome, the chromosomes, because they bring the majority of the cells, the proteins, and that's how you make a mitochondria. So that's with that in mind, I'm just going to go over some very basic stuff such that we're all on the same page. And mitochondria are ubiquitous. They are found in all organs of the body. There's no exceptions here. There's some organs that have more mitochondria than others, depending on the level of energy they require to function. So this is, I'm missing my brain. Well, not mine, but on the picture. The heart. Okay. Thank God. I mean, I put some label here. I mean, I don't know what happened there. Okay. So you can see that the brain, you would see that there's the brain, the heart, and the skeletal muscles, the kidneys. The kidneys are very rich in mitochondria. And then the pancreas, where you make insulin. So that might explain why some patients are diabetic, because their pancreas are not working well. The bones, the intestines. And that I really want to emphasize on that because it's not really well addressed. And a lot of patients complain of gastrointestinal dysmotility. They oscillate between constipation and diarrhea. It's kind of like neglected. And that's because there's a ton of mitochondria in the intestines. And the intestine, in order to work, needs mitochondria. The eye, so that's obvious for these very educated audience, the liver, and so forth. So what they all have is that all those the mitochondria in those organs make ATP. So I just want us to demystify, why do we need the mitochondria to make ATP? Why can't we just make ATP from somewhere else? Because after all, in nature, you always have a backup plan. So how come this backup plan is not working? So what is a backup plan? So I kind of like broken down into very simple steps, and just to simplify the concept is that first you have like glycolysis. What is it? So, oops. So glycolysis is a breakdown of sugar. So when you break it down, you have 2 molecules of ATP. So it's more than nothing, but it's not enough. So not only you make 2 molecules of ATP, but you make that compound that's called pyruvate that's going to migrate into the mitochondria. And that migration is essential because then this pyruvate is going to be converted to something called acetyl-CoA that's going to trigger a wheel, like a motor wheel. That's called the Krebs cycle. That Krebs cycle, every time it churns, it's going to make some products. So the output is another 2 molecules of ATP and some product that we call reducing agent, NADH and FADH2. They are going to provide electrons to trigger the making of ATP in a mitochondria. So once the pyruvate gets in, the Krebs cycle is in the mitochondria, and then it feeds the OX-phos pathway. So you have just to see the Krebs cycle as a motor. Not that I'm really mechanical, but I mean, I'm pretending here. So the Krebs cycle is a motor, and then the OX-phos are the wheels. And the OX-phos pathway is depicted here, and it's like a little bit more what James presented. But you can see that the yellow circle are the subunit encoded by the mitochondria. So the mitochondria doesn't encode so many units of those big complexes, but enough just to create havoc once you have a mutation in one of those. And the goal here is for the electrons to come here and to hop around with a little shuttle. So the first shuttle is a coenzyme Q10. That's why, I mean, we prescribe coenzyme Q10 to patients with mitochondrial disease. And then it goes to the next complex, complex 3. And then they hop on another shuttle called cytochrome C, and eventually reach the complex 4. And that's going to communicate, provide energy, mechanical energy to complex 5 to make ATP. And at the end of this process, you make 32 to 36 molecules of ATP. This is why you need mitochondria, because you can see, you can do the math. In mitochondria, we got like maximum 38 molecules of ATP versus 2 molecules of ATP from breaking down sugar. So you can see why you have like such a deficit. So then let's go over briefly, because I mean, I think that a lot of people went over those different mutations, but this is on the left, you have the result of the survey we did with Lisa and Lisa. And we realized, we asked the patients, I mean, with which mutation they were diagnosed with. Some of them were, we were surprised, but sadly so, a lot of patients were not genetically diagnosed. So I think this is something that has to be changed, because then if you don't have a genetic diagnosis, you have like a pseudo clinical diagnosis. So you can see the most frequent mutation is 11778. And then after that, that maps in an ND4 subunit. So we see when they're put in the red circle, those are the mutation with the mutation. And then the next one is, oh my gosh, I even don't read myself here. I mean, oh yeah, wow, it's okay. The next mutation is the 14484, 13%, and then the 3460, 88%. So, and then we have a bunch of least frequent one. And so I decided just to emphasize on those, because if you're a patient with genetically diagnosed with this mutation, then you kind of are nearly all by yourself, because such a low frequency that it just doesn't generate enough communication and dialogue. So I really want just to emphasize that it doesn't matter which mutation you have. I mean, what matters, because when you have it, it's 100% for you. So then we did like a correlation between the age of onset and the mitochondrial variant. And like Dr. Grumman presented the previous graph saying like, most of the patients, they become symptomatic 18 plus, or she said 22, but I guess I'm going just to make 18. But we found 3 mutations that are highlighted in blue that are found in very young patients. So that means that there's a clinical heterogeneity, not only at the level of the symptoms, but the level of age of onset. So I think that if you have a member family with an LHON mutation, whatever it is, I think it's really important just to then follow up immediately with when you have children, just to make sure that they don't have another variant that can be triggered during early onset. So we present always LHON and LHON-Plus as an adult onset disease, but there's always exceptions. But 3 variants, I think it's more than an exception. So then now I'm just going to address this mystery that we will all want to solve. Why do we have so much clinical heterogeneity, not only among patients, but among family members? So one family member can just have vision loss. Some others can just be carrier, but be asymptomatic. And some can have like extra-ocular symptoms. So what triggers that? So James actually brought up the notion of heteroplasmy, and I'm just going to bring out to another level. So he presented as a whole. I'm going just to say now, to make the statement that this level of heteroplasmy varies from cell type to cell type. So you can be homoplasmic in one cell. For example, I'm going to say the retinal ganglion cells, because those are the ones in question leading to vision loss. But it doesn't matter. You can have also a significant heteroplasmic level in cardiac muscle cells. And hence, that's why maybe when you mention in your email that you have like several patients that actually pass away from cardiac problems. So that's why we want to expand and the notion that it's a spectrum and that the patient should not, a patient with LHON mutation should not just be treated just for the vision loss, but maybe other symptoms that can appear later in life. And the difficulty here is just to find whether it's just due to common aging, like we all going through, or it is due to something else. So it's a lot of heterogeneity among the heteroplasmic level within cells. So I'm going from one extreme, the left, to the right. The extreme on the left is like a homoplasmic, and everything is fine. All the mitochondria are wild type. So that means that you produce normal ATP. If you swing totally on the right, then that means that all the mitochondria carry the mutation in question, and they are homoplasmic. And that's when usually there's symptoms. And then you have all the in-between. And that's in between we're also interested because this is maybe responsible for this intense clinical heterogeneity among patients. So if you have, there's a threshold here, and we think that above a threshold, like I'm just putting it arbitrary at 70%, then the cells in question will not make enough ATP, and then you have a dysfunction. So if you're below that threshold, you'll be maybe limping, the cells will not be super duper performant, but it will not translate into clinical symptoms. So that's why, I mean, you have so much heterogeneity. But then there must be something more because, I mean, you know, you can see that because I brought the notion that the mitochondria needs a helper, the nuclear genome to function, then you can really conceive that maybe the nuclear genome will actually modulate the penetrance of that variant in question, that pathogenic variant, meaning it can either exacerbate the penetrance or have no impact. And I think that's why, I mean, we need just to go beyond sequencing the mitochondrial genome, but doing whole exome sequencing and eventually whole genome sequencing, because I really believe that's where the secrets lie. So, and of course, like I said, then while you have some carriers that are asymptomatic, so maybe they don't have that modulator in a nuclear genome that would just tweak the penetrance, make it worse. Or maybe I could think kind of a positive manner as well. I could think that maybe the carriers have something, a modifier that would dampen the penetrance. You know, you can either exacerbate or really decrease the penetrance. And I think that's where the questions will be there. So right now, our strategy at the Children's National Medical Center and at the George Washington University School of Medicine, where I am, we decided just to build a strategy toward precision medicine, just to address this clinical and genetic heterogeneity, because we realize that one size fits all is not going to work. Because you either then yes or no, it's kind of a binary decision. And there are so many, so it's fine when it works for you, but then when it doesn't work for you, what do you do? What's available to you? So how come we haven't been there? How come we haven't achieved precision medicine? It's because there's so many unknown in terms of the pathogenic mechanism. And that once we crack that mystery, then it's just going to open so many avenues to design, to do custom design therapies for patients. So what do I mean by precision medicine? I mean that digging into the mitochondrial energy signature and the pathogenic mechanism of each patient, and see, right now you classify vision loss, no vision loss. Do you have something more or not? So it's a very broad and general categories. But we want to say, okay, among the vision loss, are you all equal or is not? What's the difference? And for that, we need just to find what is the mitochondrial energy signature for each patient. So what is your defect? Okay, we all understood that there's less ATP, but due to what? That's a question we want to answer. So because right now the design of all the clinical trials is for the average patient, and also one more important point for the precision medicine, based on the discussion that we had on the previous session on clinical trial. And what I heard is a lot of complaints from the patient and the patient's families as well, that it say, then how do you know which clinical trial is the best for you, for your loved one? It's a tough question to address, because if we don't know the mechanism behind it, specific that patient, then it's a wild guess. So then you cannot jump from one clinical trial to another one. There's also a heavy cost associated with it. So, and I think I heard loud and clear those are not complaints, those are legitimate concerns expressed by the families. So I think it would be really a win-win situation for the patient if we will go beyond the average patient strategy and really tailor to the patient. So what can we do here? What do we do in the lab and in collaboration with Dr. Goldman? Because it's a very symbiotic collaboration I have with Dr. Goldman. Dr. Goldman, she not only she comes up with a diagnosis, but also she does the skin biopsies on patients. And then we bring it into the lab, and then we derive the patient cells, and then we test them. We do all kinds of tests just to see where the deficits reside. And then we have like a battery of therapeutical compounds that we can test on each patient cell and see whether the patient cells respond to those. So I understand it's in vitro, it's not within the body, but it gives you a clue whether this patient will be a good subject for a specific clinical trial targeted with a targeted drug. And we also do something else for metabolomics and proteomic analysis. And that's where we combine all the protein that you make in a mitochondria that are specific to you and see whether there are deficits in there. So when we put together that, then we can stratify the patient to make more meaningful clinical trial. So that's our strategy here. So this is a little cartoon to explain what we are doing in terms of diagnosis in the lab. We go beyond the genetic diagnosis. We also do the energy diagnosis. So in other words, we're putting the mitochondria a little treadmill. So on the left, you have the treadmill that is going on that mitochondria on the treadmill with really low speed. So it's not doesn't need much. I mean, just like slugging along. And then say, okay, fun is over. Now we're going to make you work. So chemically, we kind of force, it's like we increase the speed dial, and then we force the mitochondria just to run really fast. And then we realize that most patients with LHON-Plus or LHON-MS have like a deficit in the reserve energy. So that means that their mitochondria are not able just to sustain this really rapid speed on a treadmill. And that leads to different symptoms such as chronic fatigue, exercise intolerance, mental exhaustion, muscle weakness, neurological symptoms, and gastrointestinal dysmotility. So, and it's essentially due to the lack of reserve energy. So then, I mean, just to end up on a positive note, because I mean, I think that we need just to bring it to one step higher, is that then how do we diminish that deficit? How can we give more reserve energy to those mitochondria, such that they might not be as performant as a patient or someone with no mutation? But when I said that if we can dial up or dial down the heteroplasmy, then that's going to have a big impact on clinical symptoms. So it would dampen the clinical symptoms. It would just improve the quality of life and so forth. Because I think sometimes it's lost that there's not just loss of vision, there's a lot more symptoms that are associated with those patients and fund those patients, and the others are not really addressed. So that's what we're doing in the lab. We are just trying to make sure that then your mitochondria can run on the high-speed treadmill. And of course, I want to thank Lisa and Martine, who is in the audience here, that has been the lead research scientist, and she has been cultivating those cells. I think she must dream at night about all your cells. So thank you so much. And it seems I'm just going to have very few time for questions because I have my plane to catch. I'll be very, like I said to Lisa, I'll be very happy to do a Zoom session with you just to go over other questions or other concepts that were not clear. And in the meantime, you can always visit our website on that hyperlink. Thank you.
Thank you so much. I'm going to let you catch your plane, and thank you so much. I will say that I posted last night, you were interviewed by the UMDF team, and I posted into our LHON community that you would be speaking today. And somebody said, oh, I've got my cell skin biopsy is culturing in her lab. Please, I feel like I'm hanging out with her at work every day, and she is an absolute gem. And so just from the patient perspective, people, thank you so much for being a gem and for all the work you're doing on our behalf. And again, thank you so much. Okay.